very good morning to all of you. First of all, I am thankful to Sir DGHS, Director Ma'am CHEB, and the state and UT governments of basically Kerala, Tamil Nadu, and Puducherry, who nominated the Siddha doctors for this training program. So I am Dr. Virendrakumar Bhakare, working as Assistant Advisor in Ministry of Ayush, Government of India. So under National Ayush Mission, there is a program for musculoskeletal disorders, Ayush Public Health Program, and I will be explaining that. So actually, National Ayush Mission is a centrally sponsored scheme where the central and state share ratios are also involved. Under National Ayush Mission, for general states, it is 60 as to 40%. 60% is the central share, 40% is the state share. For UTs with legislature also, this is same. For in case of Puducherry also, it is 60 as to 40. And for UTs without legislature, it is 100% central share. And for hilly states and northeastern states, and for UT of Jammu and Kashmir, it is at present 90 as to 10%. National Ayush Mission was launched in 2014 in as a centrally sponsored scheme to be implemented by the state and UT governments. We are providing financial assistance to the state UT governments as per their proposals submitted by the concerned states UTs through their state annual action plans and as per the provisions of the National Ayush Mission guidelines. During the implementation of this scheme, one target was given to the Ministry of Ayush that out of the 1.5 lakhs health and wellness centers, 12,500 health and wellness centers to be implemented by the Ministry of Ayush. So accordingly, we have supported the state UT governments for operationalization of the 12,500 Ayush health and wellness centers. These centers are now renamed as Ayushman Arogya Mandir Ayush. Earlier it was known as Ayush Health and Wellness Centers, now renamed as Ayushman Arogya Mandir Ayush. So Ministry has already approved 12,500, and out of that, as on date 12033, 12,033 are operational, and some are, in some centers work is going on after deployment of the manpower. Those will be also functional in the coming some 5-4 months. One point is Union Cabinet has also approved the continuation of our National Ayush Mission NAM till 25-26. These are the components of the National Ayush Mission NAM and the activities involved under these components. Two major components are there. One is Ayush Services and second is Ayush Educational Institutions. Under Ayush Services components, we provide support for some activities like Ayushman Arogya Mandir Ayush. First one I have already explained to you. These are established by upgrading the existing Ayush dispensaries, and these dispensaries are converted into Ayushman Arogya Mandir Ayush. In co-location of the Ayush facilities at primary health centers, community health centers and district hospitals. Under this co-location, the manpower and remuneration or salaries of the manpower and their training is supported by the Ministry of Health and Family Welfare, and Ministry of Ayush is providing support for infrastructure development, medicines and contingency. Under upgradation of existing Ayush dispensaries, we are also providing support for infrastructure development and contingency funds. Ministry is also supporting for upgradation of the Ayush hospital. Under this component, Ministry supports for medicines, some contingency funds and 5-6-7 manpower for running the hospital if the posts are not filled by the state government and lying vacant. So we also provide support for the salary of the manpower. Non-recurring assistance is also provided. The ceiling is up to 1 crore for upgradation of the Ayush hospitals. We provide support for supply of essential drugs to Ayush hospitals Ayush dispensaries, even functional integrated Ayush hospitals, and teaching Ayush educational institutes also. For dispensaries it is 3 lakhs, for hospitals it is 5 lakhs per annum, for Ayush teaching educational institutions it is 15 lakhs per annum, and for Ayushman Arogya Mandir Ayush also medicines support is provided under National Ayush Mission NAM. The new component is one component is the setting up of integrated Ayush hospitals. These may be 30 bedded or 10 bedded, 50 bedded Ayush hospitals we are supporting. Ministry has already supported 137 integrated Ayush hospitals till 22-23, and out of that 38 are in operational stage. Some hospitals are under construction phase, and some work is will be started because approved units are in 22-23. Then some Ayush public health programs as per the recommendations of the Niti Aayog, we have added some Ayush public health programs in consultation with the states also, and these programs, then in next slide I will explain, including the musculoskeletal disorders program. Ayush educational institutes we support for infrastructural upgradation of the Ayush UG institutions as well as PG institutions. For UG institutions we provide support of 5 crore, and for PG institutions we provide support up to 6 crores. And one is setting up of new Ayush education institutions if it is not available in the government sector, or in the government sector if number of Ayush education institutions are inadequate, then we support for establishment of the new Ayush education institute also. The maximum support under NAM is up to 70 crores. Then those were the major components, Ayush services and Ayush education institutes, and these are some flexible activities which are also supported under NAM, like yoga wellness centers, training and capacity building of the Ayush doctors, reimbursement of the testing charges, then telemedicine. Telemedicine is also important here, I have highlighted. Then training support for HMIS and DBT tracking, if required by the state government, they can propose in their annual action plan and take grant from the Ministry of Ayush. Then NABH accreditation of the Ayush health facilities. Ministry already have an MOU with Quality Council of India through its board, that is NABH, and for the assessment of the Ayushman Arogya Mandir Ayush and integrated Ayush hospitals. As of now, more than 1,300 Ayushman Arogya Mandir Ayush have been assessed, and out of that 591 have been certified by the NABH for Ayush entry level certification. These are the Ayush public health programs. These 8 Ayush public health programs have been incorporated in the NAM guidelines during the year 21-22. We are pursuing with the state's UTs for the proposals. The first program is National Program for Prevention and Management of Osteoarthritis and other musculoskeletal disorders. Then we have taken care of all the peoples may be covered under these Ayush public health programs. Like one is a Supraja, this is for maternal and neonatal intervention. I like to mention that in Tamil Nadu, one kit is provided to the pregnant woman, like Amma Megapuru Sanjeevi kit. This was also highlighted as a best practice in Tamil Nadu. We, during the National Ayush Mission Conclave also, we have presented the presentation is presented by your officers from the director offices and state program management unit staffs also. Then Vayomitra, this is for geriatric population. In Ayurveda, this program is for promotion of healthy lifestyle through school children. We have the target of covering of 75,000 schools throughout the country in the 3 years. In Ayush Mobile Medical Unit, to provide the facilities for the people where some facilities are not available, so to go there with a team having Ayush doctor, pharmacist, multi-purpose worker, and what are the requirements of the people, getting data collected from them, referring them for the treatment at our centers, Ayush centers. Then Karunya, this is for palliative care services, going door to door, having domiciliary visits and improvement in the quality of life of the people. This is the objective for this. One program is for morbidity management and disability prevention, like lymphatic filariasis. This program, lymphatic filariasis, there are some states like Bihar, Chhattisgarh, Uttar Pradesh, Madhya Pradesh, the lymphatic filariasis patients are found more in number. So we have included this program also, so that the disease also included in National Ayush Mission. The background for this, for inclusion of this musculoskeletal disorders program is this. Look at that, major cause of the morbidity and the common cause of disability worldwide. This is used, measured by years lived with disabilities. How many years the patient lives with disability? On the basis of that, this has been written. Then degenerative changes in the joints such as knee joint, hip joint, vertebrae are the commonest cause of the restricted movements. So, and there was no dedicated program for running for musculoskeletal disorders. Even NHM is providing support for for running programs for non-communicable diseases, but musculoskeletal disorders there is no dedicated program. Then 40% to 42% direct costs on the healthcare and indirect costs also due to the musculoskeletal disorders. Indirect in the sense is some people may lose their job due to the disabilities due to the musculoskeletal disorders. This is 40% in some countries and 42% in some countries. Third is community-based prevalence. As per the epidemiological studies, this is 20%, and occupation-specific prevalence is found up to 90%. Even WHO also estimates that 40% of the population over age of 60 years suffer from MSDs, and 80% of the population have back pain in their life. Approximately 1.71 billion people have musculoskeletal conditions worldwide, and low back pain is the commonest symptom observed, and this was observed in the survey in 160 countries. This is data from Global Burden of Disease 2019. And this is also available on the website of the WHO also. The need of Ayush intervention for MSDs, that I highlighted that there is no dedicated program. Ministry of Health is supporting for NCD control, and 60 to 90% of the arthritis patients use complementary and alternative medicines. So more focus, to give more focused attention. And our National Health Policy 2017, there is a mandate of mainstreaming of the Ayush. So, and SDG 3, the goal number of SDG 3 is good health and well-being. So, keeping in view, we have incorporated this program in National Ayush Mission guidelines. Then objectives, the basic objective and important objective is to improve the quality of life of the patient. And the two objectives are to provide them treatment for musculoskeletal disorders, having awareness among the people through IAC material, and getting the patients cured at our centers. Improvement in their quality of life is the most important. Then this is the strategy when we design a program. It should be ensured from which centers this program will run, how the people will be recruited or deployed, where the patients are required to be referred for higher treatments. So these are our centers: Ayushman Arogya Mandir, Ayush dispensaries, Ayush teaching institutions. We have our national institutes throughout the country. 12 national institutes are there. National Institute of Siddha is in Chennai also. Co-located units, like co-located units at primary health centers, community health centers, and district hospitals are also available. Then some research councils peripheral units are also available throughout the country, from CCRAS, CCRUM, CCRS and CCRH. These centers are available, their peripheral units are available. The doctors can also support for training, capacity building of our Ayush manforce, involvement in the outreach camps for the said program. The autonomous bodies will definitely support to the our CHOs, our Ayush medical officers and other Ayush manpower. Other linked health facilities, if any available in your state's UTs, that facilities can be used for running this program. Then these are the activities to be carried out for implementation of this program. This should be these activities program should be implemented in a program mode, not just getting the patients in our OPDs and giving them a just OPD level treatment. Follow-ups also required, referral at the higher center, maintenance of the data. These are the things to be taken care of. So these are general awareness on preventive measures, screening of the population, yoga intervention. If yoga instructors are available, they can inform about the yoga asanas which are required for osteoarthritis or rheumatoid arthritis or lumbar spondylosis or cervical spondylosis, all the MSDs. Periodical cleansing procedure, Shodhana, clinical consultations. Shodhana is a Ayurveda terminology actually. In the Siddha system, Burma therapy is also famous there. Thokanam is also, I am from Ayurveda side, but I know about Thokanam is also a therapy in Siddha massaging. Then natural, this is the Unani, Tamrik is Unani terminology, application of oil in through nostrils. Then levels of the service delivery. At community outreach, we have to conduct camps, identify the patients of the musculoskeletal disorders through these camps, and then getting these patients at our centers, registering them for that particular program. And these are activities already mentioned, campaigns to create awareness, yoga, inform them about diet, exercise and sunlight exposure, also some medicinal plants, spices from various risk and morbidity, for various risk and morbidity groups. Screening, management and referral of the cases of the osteoarthritis and other MSDs. So this is at a community level. Then first level healthcare facilities, as already mentioned, our Ayush dispensaries, Ayush hospitals, Ayush teaching education institutes can be used as a referral centers for this. Then based on the proximity of the population, if any facility, allopathic facility is available and other facilities are not available in that area, then that center can also be used for these musculoskeletal disorders. By deploying our manpower at these centers, you can use. Then allopathic dispensary or hospital, if the person falls in that severity category, so you can refer the patient at allopathic centers also. Then this is a referral facility where our Ayush teaching education institutions are mostly used as referral facility. Even integrated Ayush hospitals or any hospital that provides the indoor facilities to the patients, so that may be treated as referral facilities, where Panchakarma or Shodhana therapies or Thokanam therapies or Varma therapies that can be provided. So you can refer the patient at Ayush education institutes, teaching hospitals, even our national institutes. These centers can act as a primary centers also, because here all experts are available. They can even advise the patients, they can treat the patients. If yoga related technical experts are available, they can advise about the yoga and diet, even sun exposure for these diseases is also required. So these are all experts and all facilities are also available at these centers. So these centers can act as a primary centers also. Ensuring the continuum of the care, this is the most important point. A patient came to us, we give them treatment and we refer the patient, but whether at that referral center the patient has whether his quality of life has been increased, or whether he has get relief from the treatment, or his symptoms has been aggravated, or patient went to the other pathies. So this record to be maintained by the concerned state and UT government, especially the directorate, and submission is also required to the ministry. I will show you the data reporting format also. So these are the referral criteria. When there are expert opinions are required, or there are some certain contraindications of NSAIDs, generally people take, or doctors also advise painkillers for the osteoarthritic diseases. So if there are any side effects observed, and expert consultation is required from our systems, Ayush systems, then the patient must be referred to our centers. And further investigations, if any facility, there are further investigations are available. We are at Ayushman Arogya Mandir, Ayush, patient is coming to us, but X-ray facility or other investigation facility suppose is not available. So we will refer the patient to the higher facility or nearby facility where these type of investigations are available. Then if the patient wills to take the Ayush treatment, the allopathy people must refer the patient to the Ayurveda or homeopathy or Siddha or Unani centers, whichever is available in the nearby vicinity. Then these some points where allopathic facility we need to refer the patient to the allopathic centers also. Mostly the suspected cases of tuberculosis, malignancy, our diagnosis is suspected, is that uncertainty in the diagnosis. Then certain conditions, we have provided the treatment more than 3 weeks, 4 weeks, but the patient is not getting cure. So we must refer the patient to the higher centers or allopathic centers for having consultation with them. Then uncontrolled comorbidities such as diabetes, hypertension, patient is having musculoskeletal disorders with these comorbidities. So for their further treatment or needful suggestions from the allopathy side, we must refer the patient to the allopathy centers also. So there should be a convergence between the Ayush health department, Ayush department and health department in the states and UTs. Then these are the modalities of the implementation, how to implement the program. We know about the centers, we know about the, we have to ensure about the availability of the medicines at those centers, which is also required. Qualified manpower must be available there, like community health officers at Ayushman Arogya Mandir, doctors at our collocated facilities, and in teaching educational institution, expert persons for treating these diseases. Then health camps and awareness program, from where we will get the patients. When we go to the community, we know about their disorders, what they are suffering of, and what is the treatment available with us. We can also provide the information through our IAC material to them, so that one person may educate to the other person also. This is the role of the health camps awareness program. Then screening of the patients, referral and reverse referral criteria. When we refer a patient to the higher center, he get treated there and his quality of life is improved, then that patient must be again came to your center also, that I went there, I got the treatment and I got this type of relief, now I will continue these medicines, or you will also suggest further any intervention is required, then the patient may get satisfied with our facility provided or treatment provided. Then advocacy of the lifestyle and dietary modifications. We have to inform about the what diet to be taken, what diet to be avoided, and some sitting postures are also there. So experts from the Siddha system, they will inform about you. Even expert from the allopathy side, they will also inform you about these things. Then community mobilization. In some states and UTs, or even in all states and UTs, self-help groups are there, even panchayat, they are also involved in implementation of the programs. So they can provide you the support also, having the involvement of these members, like even some MPs, or inviting some member of parliaments or MLAs, local MLAs, or Jilla Parishad, Jilla Panchayat members, So they will also give you support for implementation of such type of programs. There is a need to have interaction with them, that we are implementing this program, we are going to the camp. So you can invite them also. The involvement of these members is also required. Comprehensive quality should be assured through our systems, all systems, Ayurveda, Unani, Siddha, homeopathy. Then cross referrals at medical colleges, CSCs, PSCs. Medical colleges, if are available, then you can have cross reference for investigations and X-rays or MRIs. If you need it for the patient, you just refer the patient, get the X-rays, MRI done, get the expert opinion, then patient will come back to you. You have a specific diagnosis also, or through not only through X-ray, MRI, through investigations also. Then periodic monitoring and evaluation is also required. Data reporting format is in the next two slides. These are the diseases for which standard treatment guidelines have been prepared in respect of musculoskeletal disorders. This slide was already shown by Dr. A. Raghu sir in his presentation also. So interventions, so preventive measures, then clinical management, therapeutic procedures, diet and lifestyle modification, then our therapies including regimental therapies or your Thokanam, or our in Ayurveda there is a Panchakarma therapy in indoor facilities. Then some Upanaha, Lep, Pichu, Matra Basti, Parishek, Sthanika, Abhyanga. These are Ayurvedic terminologies I have mentioned. In Siddha there is a Thokanam, Ilaj Bid Tadbir, this is Unani terminology for their regimental therapy. So yoga and physiotherapy. Then data collection and monitoring. Data collection is important because you are registering the patients, treating the patients, patients' quality life is also improved, they are also satisfied. You are reporting to your state government this many patient average daily OPD or monthly OPD details to the directorate level, but exactly data in respect of musculoskeletal disorders is also required to be maintained properly. That how many patients came to our center, how many registered, how many came for follow-up, how many patients we have referred, how many referred patients have been cured at their centers, or their symptoms have been decreased, or their quality of life has been increased. Then financial assistance, you ask about, someone asked about the financial assistance for this. So under National Ayush Mission now we are providing support for salary of Ayush doctor, 40,000 per month dedicatedly for this program only, 40,000 per month, and one multi-purpose worker for at the rate of 15,000 per month. This one doctor and one multi-purpose worker per block. Further 2.4 lakhs per annum for the IAC material, contingency funds and training purposes also. So this provision is per block. Yes, per center, per block actually. The doctor and the multi-purpose worker have to cover a block.
Excuse me.
Yes.
This is only for musculoskeletal.
This provision is for all the programs actually, one Ayush doctor and one multi-purpose worker, except Vayomitra, because for that Vayomitra program we have to utilize the manpower for musculoskeletal disorders. Under Supraja also there is a provision of Ayush doctor and one multi-purpose worker. Under mobile medical unit also the provision is there. For lymphatic filariasis also the provision is there. For school health program, that is Ayurveda, that is there is also provision is there. In Ayurveda the team has to cover 25 schools per month and 300 schools per year. So we provide financial assistance under Ayurveda also. So for every program except Vayomitra. Under Vayomitra, the manpower of the musculoskeletal disorders deployed under this program is to be utilized, because Vayomitra is generally related with geriatric people also. This is the data reporting format. This format is also available in our National Ayush Mission guidelines. And the things I have already mentioned, how many facilities initiated this program, how many camps have been conducted, persons, how many persons attended the camp, how many persons attended the camps during the reporting period also. Then how many facilities, how many number of patients visited health facilities for musculoskeletal problems. Then some how many patients you have provided panchakarma therapies or regimental therapies or thokanam or any siddha related interventions. Then indicators of clinical improvement, what you have designed, that there are 2-3 scales for measurement of how the quality of life of the patient has been improved, like WOMAC scale, WAS score, reduction in intake of allopathic medicines. If the patient was taking allopathic medicines and due to our interventions there is a reduction found in taking allopathic medicines, then you have to mention those numbers. Number of patients with overall satisfaction, the SF36 questionnaire has been developed for which patients were present when the patient came to us, and how you assess after his treatment is completed, how quality of life is improved. So this is WOMAC scale I have mentioned in my PPT, so you can hyperlink this once. There are 24 points under this scale. Most of you may be aware about that. नहीं, एक मिनट, इसको करो hyperlink. There are 5 items for pain, 17 items for the physical function, and 2 items for the stiffness. So 0 for no pain, 1 for slight pain, 2 for moderate pain, 3 for very more than moderate, and 4 for the extreme pain, severe pain. So these are some points, these are routine activities we do daily: walking, running, wearing socks. So all the points are mentioned here. So you score the patient before treatment and after treatment, so you can assess based on the score. Then one is visual analog scale is also there.
Excuse me, sir.
Yes.
This WOMAC scale is free to use scale, or
This is generally for osteoarthritis. It is generally used.
okay, sir. Is it free to use scale, or we have to obtain permission from them,
No,
from the publisher?
no. When you are running a program, this scale is already standardized scale. So you can, when the patient came to you, you can take the symptoms, what is the score, and after treatment you can take this. This is just for how you assess the quality of the life life of the patient has been improved. On what basis you will say that?
Okay, sir.
This is for just our analysis I have mentioned. One is visual analog scale. This scale there are demarcations like 0 to 100 in millimeters, and the patient is asked to, we draw a line on paper. Patient is asked to highlight the severity, where is the pain, he marks. Then on the basis of his marking, visual analog scale, we can evaluate. मेरा PowerPoint में जाना कि where he mark, whether it is between 0 to 5, then it is 0 to 4, then it is no pain. Then 5 to 45, mild pain. 45 to 74, moderate pain, and 75 to 100 is severe pain. And this is most important actually for us, even more important than WOMAC and visual analog scale. This is SF36 questionnaire. This SF36 questionnaire has been designed based. देखिए इसमें बहुत there are too many points. Like one point is for general health, and other points are also there. Total questions are mentioned. 36 questions are there. On this basis also we can have how the quality of life of the patient has been improved before treatment and after treatment. So this scale is designed for the quality of life of in respect of the quality of life has been improved. So we can use this scale also. Go to my presentation. Just Google it. You will have the SF36 questionnaire. Next is record maintenance. This is the most important slide. When the patient came to our center, what record to be maintained for running a program in a program mode. These are every patient details we required: registration number, name, age, gender, ABA ID. If not generated, tell the patient to generate his ABA ID also. What are the symptoms? What is the provisional diagnosis you made on your expert knowledge? Then what is suggested to the patient to come for follow up in next week or 10 days or 1 month, or the patient is referred at the higher center. Then record must be maintained at higher center also, okay, how many patients have been referred to us and how many patients then go back to the, we refer to the said dispensary or unit. Then implementation in a program mode is required, just not registering the patients and maintaining the record, but what exactly the output and outcome we have achieved, what was the output and what is the outcome we have achieved. These, why the need of the musculoskeletal disorders, standard treatment guidelines for musculoskeletal disorders. So this was also explained by the Raghu sir, why the need. There are certain points like ICD-10 and 11, then the supportive investigations, prognosis, standard treatment, what is the recommend. I have mentioned in my slide about diet, lifestyle, yoga, but what diet is recommended, what lifestyle is recommended, what is the yoga, so that is mentioned in standard treatment guidelines and the expert will explain to you. And these are the states which and UT governments from which we received the proposal for the musculoskeletal disorders. I think Kerala is here, Tamil Nadu is also here, and Puducherry we have not received proposal. I think they may be projecting in current year SAP. So these are the number of the blocks actually. Units means number of the blocks we have approved this program in 18 states and UTs during the year 23-24 for running in a program mode. Kerala I visited also. The deployment was not done by the state government till date due to the election and code of conduct is there. So after that they will be implementing this program in a program mode. Thank you so much for listening me. There is a need of convergence between the Ayush and health departments in among us also. For example, if there is a Ayurveda dispensary or Unani dispensary or other dispensary is available there, and doctor is treating, patients are registered for musculoskeletal disorders and doctor is treating that disease, and he requires higher patient requires higher treatment or higher centers referral is required, and there is a Siddha hospital nearby the facility, then that doctors must be encouraged that here are the treatment is available. You should have interaction with them. You can refer the patient at our facilities also, and vice versa. If the Siddha facility is available and nearby Ayurveda or Unani homeopathy facility is available, and their treatment facilities are available for these diseases, then the Siddha people may refer the patient to that facilities, and even in cross-pathy also. So there is a need of convergence in between us, among our systems, and in among the states also, and this should be planned in all the states and UT governments, not only in respect of your states where Siddha system is prevalent, but in other states where Ayurveda, Unani, they can refer among themselves also. Thank you so much for listening me so politely. Any question if you have, you can ask. SF36 questionnaires, yes, we can use. It is already incorporated in our National Ayush Mission guidelines we have mentioned. ठीक है ना? Any doubt? For SF36 questionnaire, you can just Google it. SF36 questionnaire, you will get it. ठीक है? Okay. This presentation will also be provided to you also. Or they will, CHEB will be sharing with all of you. Any doubt?
Sir, first of all, we are thankful to you for bringing out this initiative for sensitizing medical officers working in rural areas. And one humble request that I would put forward to you as assistant advisor to Ministry of Ayush is especially with respect to the Kerala scenario. The Siddha system of medicine is weak I mean, in the government sector, there are minimized manpower. So I would humbly request you to put forward a coordinator or a nodal officer or a doctor of rank similar to that of an state program manager under NAM to coordinate and look forward all the activities of Siddha, especially for the promotion of Siddha in the state.
I have noted your point. I have visited Kerala state in the last month also. There are two state program managers. One is for Ayurveda and one is for homeopathy is available at the state program management unit. Those both are regular officers of the state government and they are looking after the National Ayush Mission NAM. But there is a dedicated team is also available with them. And your point is noted down, and we will request to your mission director, Dr. Sajid Babu sir, also to take care of Siddha system related people also.
Now, sir, I just request you to create a post of a state program manager, especially for Siddha. Only then the system will be coming forward.
Actually, under National Ayush Mission guidelines, there are 7 posts must be in the state program management unit, and one of the post is state program manager. But in case of Kerala, they have deployed their regular manpower. So we will request for Siddha system to them. State government of Kerala basically.
Okay, so another thing is you spoke about convergence of systems, especially where IMG is very strong in Kerala. The convergence it has to come from the top level.
Okay.
I mean, from the center to the state. Only then it would be, as medical officers, we could interfere.
No,
Even though referral centers and hospitals are available near to our centers, but then it is a referral from an Ayush sector is not that much accepted by the allopathic or the conventional systems.
So this is for this purpose, state government is also to take some meetings with the allopathy side persons, and there should be a convergence among them. I have seen the Karunya program in Kerala. That is, they are providing training to the Ayush doctors and allopathy doctors at one place. So
Yeah,
that is a good practice.
Recently that we had a program linking all Ayush sectors and allopathy in the palliative sector. But then this would be of highly useful when we implement in the musculoskeletal system. In this pattern or in this particular project also, if you are going to integrate it, it would be highly beneficial.
We will discuss in the ministry also, and we will discuss with your mission director also. Your point is noted down.
So another one thing, you spoke about, medical college, where there is an unavailability of colleges in the government sector. In Kerala, there is only one private medical
Siddha.
college, Siddha Medical College, run by Shantigiri Ashram. So if you could let us know about the procedures, how to, bring about a government medical college in Kerala. I think we
Actually,
could follow.
I got your point. The public health is a state subject, and establishment of any hospital or dispensaries or colleges, this also comes under the purview of concerned state or UT government. But under National Ayush Mission, there is a provision to support the state UT's governments for establishment of new college where it is not available in government sector. So you are saying about there is no government Siddha college in Kerala. So state government can propose through annual action plan as per the provisions of the NAM guidelines. I can share with you the NAM guidelines. So if you go through that, you have an idea that how the proposal is required to be submitted. The proposal is required from the state government through their state annual action plan, which is even chief secretary is the head of the governing body. So meeting is also held at executive body meetings and governing body meetings. At the state level this happens, and then thereafter, after obtaining the approval of the governing body, they submit us the state annual action plan to the Ministry of Ayush. Then that SAP is discussed at the central level in the appraisal committee meeting under the chairmanship of joint secretary, admission directorate meeting under the chairmanship of our respected secretary sir. So and at that time those are the approving authorities and competent authorities whether the proposal is as per the guidelines or not and it is feasible or not or to approve or not. So if the state government submits us, we will definitely support. We have already supported 12 to 13 Ayush education institutions, new institutions.
Thank you, sir.
Thank you.
Just for your information, last year we got one Siddha Medical College permission for Government of Puducherry. This
Yes.
is for your information, doctor.
Yes.
Last year we got permission for a new Siddha Medical College in Government of Puducherry. So your higher official can get in contact with our director in Department of Ayush in Puducherry so that he can guide you in this meaningful time.
Okay.
Thank you.
Thank you. Thank you, sir. Thank you. Thank you to all of you, and I am thankful to yours once again to your state government, UT governments for deploying you for this meaningful training program. Thank you.